everyone. Let's try that again. Good evening, everyone. Oh, we might as well do it for the third time. Good evening, everyone. Everyone, oh, thank you. And if you didn't hear that, what she said was, I'm Dr. Linda Scott, and I am proud to serve as the AD of the UW-Madison School of Nursing. It is a once-in-a-lifetime pleasure to welcome you to our signature event to kick off our Centennial Weekend celebration. Whether you're here in person or remotely, I am grateful that you chose to be with us this evening. It has been front and center in our minds that we are celebrating because of you. You have shaped our history, strengthened our present, and made it possible to set our sights on transformative change in the future. As we began envisioning how best to culminate our milestone year, we knew that incorporating the Littlefield Leadership Lecture was fitting for our tradition of celebrating nurse leadership. In its 25-year history, Littlefield Lectures have consistently drawn on the lessons of the past and present to look ahead at how the nursing profession will navigate what is on the horizon and to lead change. This centennial edition of the Littlefield Lecture is focused on the School of Nursing as a source of expertise and leadership, and I am truly proud to share it with you. This is in keeping with what the Friends of the Littlefield Lectures had in mind in establishing this series. I would like to thank them for their dedication and ongoing support of this series and its purpose, so please join me in thanking our Friends of Littlefield. I know many of you were colleagues and friends of Vivian, and that she is remembered fondly by many, including myself. And I am certain that Vivian would enjoy tonight's event and the lecture's focus on preparing nurse leaders for impact through public and population health nursing. We're going to begin with brief opening presentations from each of our three Littlefield speakers to contextualize the perspective they will draw on during our conversation. Our three co-presenters are Dr. Susan Zahner, who recently retired from the School of Nursing as Vilas Distinguished Achievement Professor and Associate Dean for Faculty Affairs. Dr. Zahner is widely recognized for her contributions to public health in the integration of nursing research, education, and public health practice. Susan's opening remarks will provide background on public health and the school's legacy of impact in this area. Susan will be followed by Clinical Associate Professor Dr. Kate Gillespie, a public health nurse and faculty member with deep experience in clinical practice, public health, systems leadership, and outreach. Dr. Gillespie leads the population health specialty in the school's Doctor of Nursing Practice program. Her opening presentation will focus on preparing nurses for population health impact through practice. And our final presenter is Dr. Maichou Lor, an assistant professor in the School of Nursing. Dr. Lor's innovative research includes delivery of care, health literacy, and quality of life for patients with communication challenges, particularly those with limited English proficiency. It is worth noting that Dr. Lor is a multiple Badger nurse. Yes, and you're going to hear about why. She earned her undergraduate and master's degrees, a certificate, and a doctoral degree, all from the School of Nursing. And I will also tell you that she is the first Hmong American nurse to earn a PhD in the United States. She will present on addressing health literacy through the lens of language and culture. So we're going to begin our conversation immediately following their opening remarks. And now I invite Dr. Zahner to the podium to get us started. Susan.
Thank you, Dean Scott, for your invitation to speak at this wonderful event. So I'm a public health nurse. I first became aware of public health nurses when the county nurse came to my school to test my vision. Here was a nurse that didn't work in a hospital. Here was a nurse that cared about health promotion and who assuring access to care. I think that she understood what we now call the determinants of health. And she cared about the health of the entire population of my rural county. So in the many years since then, I've had the chance to work as a public health nurse in a variety of settings. I was educated in public health research and practice. I taught skills to public health nurses required for the job, and I led and collaborated on a number of research and scholarship projects around public health. Those years of work and experiences confirmed my beliefs in the critical importance of public health and the essential roles of nurses in the public health system. Lillian Wald, most of you in the room probably heard that name before. Lillian Wald first used the term public health nursing in 1912. By public, she meant all the people as a whole. Okay, thank you for that little reminder. By public, she meant all the people as a whole. And by public health nursing, she meant nurses doing the work of social betterment for all people. So that's really what I mean, too, when I talk about public health nursing. The school has a very strong legacy in contribution to public health nursing education, research, service, and leadership in Wisconsin and well beyond. I'll just mention a few examples here in education, research, and service. So even before the school was founded, the UW Extension and the Wisconsin Anti-Tuberculosis Association in 1918 offered an 8-week course in public health nursing, reflecting the importance of nurses in the fight against tuberculosis. Our first bachelor's degree in 1939 came with a public health nursing major. It was then called hygiene. Since at least the early 1970s, global and rural health immersions led by faculty have given students rich public health practice experiences in places like Nicaragua, Uganda, Thailand, and rural counties in northern Wisconsin like Barron, Rusk, and Door counties. In 1974, the primary and secondary undergraduate curriculum was introduced, showing true innovation in preparing nurses for roles in public health and primary care, in addition to roles in the hospital and other care settings. Over many years, the Masters of Science in Community Health Nursing produced public health nursing leaders who worked around the state of Wisconsin and beyond. In 2005, we innovated to create the MS-MPH dual degree option with our School of Medicine and Public Health partners. Dr. Gillespie is going to be sharing information about our newest curriculum in public health leadership, the DNP in population health. Many faculty over the years have conducted grant-funded interdisciplinary global health and rural health projects, research projects, and practice projects. Over 6 years, I led the Linking Education and Practice for Excellence in Public Health Nursing Award that was a federally funded project that brought schools of nursing and public health agencies from across the state together to improve public health nursing practice and education. With Robert Wood Foundation grants, I studied public health partnerships and local public health practice improvement. And with ICTR funding, we created the New to Public Health Residency Program, which is an innovative national online 12-month residency program for public health professionals, nurses, and others starting their work in governmental public health agencies. Many faculty, students, and postdoctoral trainees have conducted research around public health interventions and health equity issues for key populations in the U.S. and beyond. And Dr. Lor will be sharing more from her research as a current example. With regard to service, the school has a strong legacy in that area as well. The Blue Bus Clinic was a free community clinic started in 1969 by UW students, including student nurses. In 1994, faculty partnered with the School of Medicine and Public Health. Actually, I think it was the School of Medicine then, excuse me, the Madison Public Health Department, donors, and community agencies to open the South Madison Health and Family Center, also known as Harambe, to serve a multicultural, diverse, and low-income community in Madison. Nursing faculty over the years have served on local boards of health and state-level public health committees. Our students and faculty engage in annual influenza clinics on campuses, on farms, in senior centers all around the region. During the COVID pandemic, we led a Wisconsin Partnership Program award that engaged other UW system nursing schools and their students in a statewide effort to immunize the entire population. Badger Partners in Health and Safety is a partnership with the vet school to bring health promotion activities to farmers. Faculty and staff are engaged in evolving global and planetary health programs. And there are many other examples, and I'm sure you have examples that you could share at your tables. But some are focused on more specific populations, like our Center for Aging Research and Education's work in healthy aging in rural areas of the state, and the development of resources for school nurses. In sum, the school can certainly be proud of our legacy in public health education, research, and service, and we must strive to build on it to address the many present and future challenges in public health. So population health improvement requires collective action to address the many social, environmental, and behavioral determinants of health, to address racial, gender, and geographic discrimination factors that are known to perpetuate health inequities across groups. Some of you may know that the U.S. spends 4% of the total health dollar in public health. But to improve public health, we need to invest more in public health approaches that are evidence-based and that have been demonstrated to have a strong return on investment with benefits accruing at the population level. And we must address clear, present, and evolving threats to health, including misinformation and disinformation about public health, climate warming, resulting in more climate emergencies, climate migration, and ongoing environmental injustice, rising mental health concerns across all ages, and chronic underinvestment in the public health system. Population health improvement requires collective action, and collective action requires that nurses work in partnership with communities. And nurses are also needed in leadership roles and to be the agents for change that we know we can be. I proudly call myself a public health nurse. I appreciate the vital importance of nurses working to improve the health of all people. And I know many of you in the room feel the same. I look forward to further discussion. Thank you.
Okay, hello. So let me start by saying it is an honor to be here with all of you today. As Dr. Zahner mentioned, I'm going to talk about how we are preparing nurses for future roles in population health. Sorry, I was a slide behind. So I want to start with a look at the current state of health in the United States. So the Commonwealth Fund recently released a report comparing healthcare systems across 10 countries that included the U.S. They found that Americans face greater barriers to accessing and affording healthcare, and that we trail other developed nations in equitable health care that has resulted in Americans having shorter lives. Over the past 2 decades, the U.S. has implemented significant policy changes to healthcare reimbursement that are driving accessibility and accountability and a greater focus on population health outcomes. However, it is not access to healthcare coverage or healthcare itself that are primary drivers of our lagging behind in health outcomes. Rather, it is social, economic, and environmental drivers that are affecting the health outcomes and the life expectancy of all Americans. Where we live, work, and play largely determines our opportunities to be healthy. Healthcare in the U.S. has been pushed to shift toward a focus on quality, cost, and the patient experiences. Quality and safety have been strong foci across health systems for over 2 decades, widely driving improvement efforts. Yet the persistent inequities in health outcomes remain unacknowledged as working against quality and safety. As Kedar Mate stated in the 2024 Institute for Healthcare Improvement Conference, there is no quality and safety without equity. I'm going to say that one more time. There's no quality and safety without equity. To achieve health equity, we need strategies that are population-based and that integrate systems. We need healthcare workforce, a nursing workforce that is prepared to lead us toward better, more equitable outcomes. We must look for solutions to health issues upstream, no longer focusing on one person at a time, but instead looking at the conditions surrounding that person in the community in which they live. Nurses need to use their foundational skills to collaborate across the healthcare continuum to design programs and activities that will prevent injury and illness and manage diseases toward equitable population health outcomes. Nurses are uniquely equipped for the challenge to shift to population health. We only need to look back at our past to find the skills that we need to move forward. Nurses have a long history of focusing on the whole person and the whole community. What's different today is they need to apply this view in the context of large systems of care spread across multiple communities. Nurses have the capability of bridging the systems that individuals and communities interact with and rely on, like transportation, schools, housing, and food security, with health. Nurses have long been advocates for patients and families. Today, we need them to advocate for population groups. Nurses must master technology to assess populations and design interventions to support their health holistically. Nurses are accustomed to partnering with patients and families in planning their care. Today, we need them to partner with communities and partners to support them in finding and sustaining solutions for healthier environments to thrive in. Public health has historically been an essential component of nursing education. Today, public health has shifted from a focus on disease prevention to systems interventions, intending to drive population-level change. We need nursing education to move toward a focus on population health with the understanding that it spans the continuum of care. In keeping with our history, here at UW-Madison, we have accepted this challenge and are preparing advanced population health nurses through the DMP in population health. The population health DMP students are learning to think upstream. This curriculum provides advanced practice nursing skills with a strong focus on leadership, epidemiology, and policy to improve population health. It also includes a unique focus on communication and convening a wide array of partners toward a collective impact for optimal community health and wellness. Our graduates are prepared to assume advanced leadership positions across the continuum of care at the local, state, national, and global levels. Graduates of the DMP in population health are prepared to do such things as bridging epidemiological data with the community's lived experience of illness and health. They are conducting population and community assessments to understand and design systems-level programs that will drive equitable distribution of health services to strengthen communities and assure community resilience to weather the impact that current and future environmental and planetary climate threats pose. They are doing all of this with a focus on the principles of social justice to identify policy and solutions that can eliminate health disparities. Graduates of the DMP in population health will be working across the population health continuum in public health nursing roles at the local, state, and federal levels, in community-based programs, and across school systems. They will also work within health systems, leading care management and coordination, population management programs, and building models of integrated care, all while maintaining a nursing holistic approach that guides a therapeutic relationship with individuals, families, and communities for the provision of appropriate nursing interventions toward better health outcomes. Thank you.
All right, good afternoon, everyone. I will now present a key example of the upstream approaches that Dr. Gillespie mentioned: partnership in addressing health literacy for non-English speaking populations in the context of language and culture as social determinants of health. It is clear that where we are born, live, work, go to school, or raise our families can make a significant difference in our health outcomes, quality of life, access to healthcare resources, risk for disease, and even our own safety. In the US, public health and in social and behavioral sciences more generally, those social and physical conditions are referred to as social determinants of health. Research indicates that individuals and communities living even a few miles from one another can experience vastly different health outcomes, with minoritized communities disproportionately affected. Communities with low health literacy, compounded by language and culture factors, experience serious health disparities. These health disparities can be traced to a history of social linguistic segregation, discrimination, and weak investments in neighborhoods where they live. This population also may experience socioeconomic disparities and participate in diverse cultural practices related to health and illness to which their healthcare providers may not know how to respond. And the healthcare system does not always provide adequate services to allow them to access the care that they need, a phenomenon known as health literacy. Health literacy has evolved from being seen as an individual attribute, skills like the ability to find, understand, and use health information, to focusing on the interaction between individual and the system. This shift highlights the need to address both individual abilities and the demand and expectations of the healthcare system. By demand and expectation, I mean that health literacy is an interaction not only involving patients, but also clinicians. The effectiveness of communication depends on the skills of the communicator, the complexity of the information, and the surrounding circumstances. Recently, the term health literate organization and health literacy environment have emerged to describe how the demand and complexity of the healthcare system and society at large makes it easier or more difficult for people to navigate, understand, and use information and services. It has been documented that people with low levels of health literacy are associated with poor health outcomes, high hospitalization, and death, or you may even experience longer stays in hospitals. And the list goes on, as you see here. My point here is to say that health literacy contributes to health disparities by making it harder for disadvantaged individuals to access, understand, and use health information, which exacerbate inequalities in health outcomes. Compounding the issue is language. Language affects health literacy. A large number of people in the U.S. have limited English proficiency. Approximately 68 million U.S. residents speak a language other than English at home, and approximately 28 million speaks English less than well. Research has shown that language discordant encounters, or in other words, encounters where patients and clinicians do not speak the same language, results in worse health outcomes, reduced access to health information, and decreased satisfaction with care. Language barriers exacerbate health literacy challenges. Now let's think beyond just words and language. Culture deeply influences how we perceive health, illness, and healing, as well as how we interact and communicate with others. In many cultures, for example, mental health might carry a stigma, or there may be different beliefs about what caused illness. Now, I want you to imagine if you were handed a brochure about managing chronic disease that doesn't align with your cultural values, norms, or language preference. Would you trust it? Would you follow its recommendation? When we fail to consider culture in how we communicate health information, we risk alienating the very people we're trying to help. Study shows that addressing health literacy with cultural understanding is key to building trust. It shows people that we respect their experience and values. Trust is the cornerstone of good healthcare. Patients who trust their providers are more likely to follow medical advice, engage in preventative care, and seek medical attention sooner when needed. Thereby, we get closer to reducing health disparities. Building trust is foundational to establishing effective Building trust is foundational to establishing effective partnerships. I firmly believe that fostering strong partnerships between classrooms, communities, and health system is a crucial upstream approach to advancing health equity. Community-based interventions and partnerships bring together healthcare systems, schools, local organizations, and residents to co-create solutions that are tailored to the need of the population. There is substantial evidence showing that building partnerships with communities improve health outcome, especially in addressing health disparities and promoting health equity. I will look forward to diving deeper into this during our conversations shortly. I'd like to conclude by sharing a quote from Executive Director of the American Public Health Association, Dr. George Benjamin. "Health equity is a goal we can achieve, and it's within our power to do so. When we have the tools and the knowledge to make health equity happen, it's up to us to make use of them." Thank you.
So thank you, Dr. Zahner, Gillespie, and Lor for your introductory comments. We are excited to hear more what you have to say during our conversation. I have some prepared questions for you, and then we'll have an opportunity for both our in-person audience and our online audience to ask questions as well. And I think I want to begin with Dr. Zahner. In your remarks, you mentioned 4 key areas to improve public health in the future. Which one stands out to you and why?
We make it hard to say just one, but I think as a society we really need to increase the resources provided to public health strategies that have high return on investment across populations. As Katie mentioned, there are many countries in the world that are spending much less money than the U.S. but getting better health outcomes. We can do that too. The boom and bust cycles of funding public health in emergencies and then cutting back when the emergency is over really should stop. High return on investment public health strategies are things like vaccination programs, tobacco taxes, early childhood programs, prenatal care coordination, chronic disease management programs, and universal access to high quality primary care, safe housing, and education. These are all things that are upstream in their approach. They focus on prevention and health promotion and in ways that are equitable across all segments of the population. That's how we get to population health improvement, I think. I also want to mention that it's critical right now with the upcoming change in administration at the federal level to consider some things. You know, I have lived and worked through a number of transitions in governments over the years and worked in public health during those times. And in every case, the change in leadership causes uncertainty about funding levels, program continuation, agency leadership, and changes in regulations. Given statements that have been made recently, I think we have reason to be concerned, but as we all know, what is said and what actually happens can be very different. So all of us interested in population health improvement, I think, must ask and listen without making assumptions or judgments, and we must continue to build and draw on evidence to educate and advocate for programs and services we know to be supportive of population health. And finally, as I mentioned before, as nurses, we need to be participants as vocal and visible leaders in system improvement. Society needs nurses up front, visible, leading the way for all people and the planet, now more than ever. Okay?
Thank you. Thank you, Dr. Zahner. Something that really resonated with me, and I don't know if it did with our audience or our other speakers, was when Dr. Gillespie made the quote about there being no safety and quality without equity. I'm wondering if you wanted to elaborate on that, or if Dr. Lor or Dr. Zahner would want to comment any more about that.
I'll start and then turn it over to the others. Essentially, it means that in our healthcare systems across the continuum of care, we all have to adopt a focus on equity. And equity has to be primary. And we can't continue to focus on quality and safety and think that we're actually going to achieve high quality and true safety for everyone until we decide to focus on equity as well. So with that, I would challenge all of us working in healthcare today to incorporate equity in any quality improvement effort that is implemented across a healthcare system.
Thank you. Dr. Lor, Dr. Zahner?
I just wanted to also clarify this terminology for health equity. Oftentimes, when we think about health equity, people often assume it's health equality. And it doesn't mean that we treat everybody the same, but we have to really meet where communities are. And I just really want to put a plug and emphasis on how we best stress health equity by meeting the community where there are. It's not necessarily providing the same type of services or care to everybody the same way. There's a difference. Thank you.
Thank you. Dr. Zahner, any comments?
Just to say that if you think about it, if we're trying to improve the health of the whole population, and our programs and services only work for one group, we're not improving the health of the whole population. It doesn't help to continue to have a gap between different segments of the population. So we really have to do both equity and overall health improvement for all.
Okay, great, thank you. Dr. Gillespie, could you share what you think are the most important traits of public and population health leaders in the future? And then I'm curious, what are you the most proud of our graduates in this space?
Sure. So I think there are two things I would highlight as being essential for public and population health leaders. One is to have a good understanding of data, understanding how to work with data, and using data to portray the picture that you're trying to convey about a population. And you need to be able to work with that data so that you can create a message and translate it for a variety of different audiences. And that means that you have to consider yourself as the interpreter. So you become an interpreter of data. You're not necessarily the creator of data, but you are the interpreter of data to help people to understand what it is that is critical for this population? What is the health issue, and why does it matter? And so I'd say that data is really important for anybody leading in population health. The second thing I'd say is communication, and I think they go together. So communication, as we all saw with the recent pandemic, wasn't exactly stellar across the board. There's a lot of room for improvement in public health and population health around communication. But again, it amounts to communicating for different groups of people, different audiences, and being able to convey that message using the language and terminology that is effective for that group of people so that they will understand what the concern is, what the issue is, and what the message is. And so putting the two together, using data to create the picture, and being able to communicate effectively with many different people. I think nurses are well prepared for that. Nurses are used to that. Walking into a patient's home, walking into a patient's room, and having to convey and explain what was just said by a medical provider that walked out, for example. And nurses are translators. And I think nurses are key to population health leadership for that reason.
And what are you most proud of?
So our graduates have made me very proud. We recently graduated our first cohort from the DMP in population health. And these amazing professionals are doing things like working with the National Association for School Health Nurses to connect school nurses with clinical health systems, pulling them into the fold of the healthcare team, and also working to establish Medicaid reimbursement so that the work that school health nurses can do can continue to support children and their families. Parents can stay at work, children can stay in school, and communication is effective back to the primary care provider. Another example is a graduate who has been working in Fond du Lac County, Wisconsin, to establish a task force to help seniors stay in their homes safely. They're bringing partners together, like volunteers that deliver Meals on Wheels, for example, to connect with seniors in their home and assess for fall risk and make sure that people are living healthily. And this is because we know that there's a shortage of spaces for long-term care facilities. And nurses leading task force to help people stay in their home is going to be more essential as we move forward. All of our graduates have done amazing work in supporting education going forward and continuing to bring on the next population of nurses. And they are presenting and sharing the wonderful work that they're doing at conferences.
Great, thank you. So, Dr. Lor, so again, communication has been a theme in some of the responses that we've shared in your presentation. What do you think is the best way to prepare students to engage with and communicate among different populations? How can we make sure that they're practice ready to do that?
It's a very hard question. It takes lots of different approaches. I don't think I have the best answer here, but I think the best practice in terms of preparing our students includes cultural competence training, providing firsthand experience in diverse communities, and using simulations that reflect real-world scenarios, as well as integrating interprofessional education along with mentorship from experienced professionals to really help foster empathy, cultural humility, and skills to address health equity. That would be my short response. I also want to emphasize that because we know that some of our students go into research, and so I think it's also very important to engage our students in community-based participatory research, where students are collaborating and partnering with communities from the get-go to identify the health concerns and co-create solutions to address the issues of the community. And I think this is more of a equity approach to really enhance culture competency training. And I also think that by engaging students with community-based participatory research, it would allow the students to get a deeper understanding of not just the challenges, but also the strengths in the community and their needs to be able to tailor and create solutions that work for each communities.
Great, thank you. Another reoccurring theme that I've heard from each of you has been about partnership and collaboration. Why do you think that's the case? And what do you think that we need to do to make sure that we strengthen and engage in those types of relationships, being outward-facing with our communities? And I'll let any one of you or all of you respond.
I'd be happy to start that. I think that partnership is important because nobody can do this alone. I mean, population health improvement is huge. It's never ending. And it's a goal that really can't be accomplished by any one group. We have to work together. And then also factors that drive population health, or drive anything at a population level, just as at an individual level, they're complex, they're varied, and they're many. And so there's a lot of different disciplines that have expertise in those areas, and more importantly, people have expertise about their own experience, and communities have that expertise as well. So all of the research we do, the education practice, policy advocacy, all of that requires understanding the perspectives of people that are affected and understanding the conditions and the system in which they are, which provides the context. And so we have to understand all of that. And it takes a lot of people to do that, as well as a lot of people to plan together and figure out how best to change things. So we need the expertise of many to get this done.
Okay, great. Katie?
Yeah, I'll add that, you know, when in public health, when you're going out and working with a community, it is critical to partner with people in the community, because the goal isn't to always need public health nurses to come in and fix everything. The goal is to help the community find a way to do it for themselves. So the partnerships are essential for that. And then I'll also say that one of the things we used to always say at the Department of Health Services is health in all policy. And I know that we weren't the only ones saying that, but it's important for people around the state and in communities to recognize that a lot of the policy that they're focusing on, a lot of the policy that they're striving for is going to impact health. And it is always important to look for the ways that that might occur and to anticipate what to prepare in advance in order to protect health. And you need partners to do that.
Okay, great, thank you. I'm going to ask one more question of our panelists, but following that, I'm going to open it up to the audience, and if you have questions, I would like you in the room to raise your hand, and we have individuals in the room who will bring you a mic, and then for those of you who are online, there is a Q&A button on your Zoom platform or in the chat, and we'll monitor that as well. So my last question for our panelists at this point, and I heard you mention this too, we know that our public and population health workforce consists of many disciplines. Why do you think a nursing perspective is important to be at the table and in the lead?
I'd love to start that. I think there's three things to say here. A former mentor of mine, Dr. Marla Salmon, some of you may know her, she talked about nurses as being the most flexible of public health professionals. And I think by that she meant that nurses have a clinical background, so that allows them to provide interventions at an individual and family level, while also having the understanding of health in communities and health systems to be able to operate on that system, community and system level. Nurses are also, as we just talked about, great at collaboration and communication and facilitating active partnerships. We like teamwork. That's how we operate, and so that's great. And second, there is actual evidence that nurses are effective as public health leaders. Some recent research that was done by Dr. Paula Kett examined national data on health outcomes that compared public health jurisdictions that had nurses as their leaders compared to ones that did not. And they were able to document statistically significant differences in health outcomes in the jurisdictions where there were nurses in charge versus not. And that is pretty powerful. Another study by the same researcher found that where there were nurses in the head position, they were more likely to have community assessments, community improvement plans, and to include the social determinants of health in their policy plans. So they're doing the things that need to be done in those settings, maybe a little better than some leaders in other areas. So I think nurses are important because we're good at this.
Thank you, Dr. Zahner. Badgers out there, a lot of Badger nurses, and a lot of friends of nurses out there. I am sure that you have questions for our panelists. If you could please raise your hand, and we'll bring a microphone to you. And all the way up in the front of the room, if you can. And if not, I'll hand you my mic. Right here. Okay, well, Megan's making her way to the front of the room. Right here.
Thank you.
Yeah.
So I agree with the statement of quality and safety can't be achieved without equity, but I also feel like having worked in public health, I have the opportunity to learn that, right? I have the opportunity to see how that works. But as we start to see public health, elements of public health and population health being moved into the healthcare system, right, to our very complex healthcare system, do you have any thoughts or ideas or suggestions on how we keep equity at the forefront from becoming a buzzword, right? For becoming a task that needs to be completed, but rather a way of really practicing and recognizing that we really can improve health outcomes for everyone if we have that lens. But we know everyone doesn't have that lens. So I know you can't solve this problem tonight, but I think it's something that we should think about because we want to see this moved in across our healthcare system.
Thank you.
Sure. So, you know, when, I don't know if any of you watched the IHI conference, but I did watch it remotely. And when Kedar Monte brought that up, what he was basically saying was that, you know, we have created, in an effort to establish, you know, a systematic approach across these large, complex systems, we have moved to this sort of cookie-cutter practice, and for lack of a better phrase. And it's designed to make sure that we're doing things the same way always, and in hopes that that will always be safe and we will always maintain quality. Probably driven by, you know, federal regulation, but what it's done is it's allowed us to ignore the differences across population groups and to try to mold everybody into fitting into that cookie cutter. So what we're going to have to do is to chip away at that a little bit, and to allow nurses to bring back what they're very good at, is focusing on the differences across the population groups, across people, and understanding all of the factors that are impacting that person's lives and what landed them in that healthcare system in the first place.
Can you hear me now? Okay, perfect. I would like to say that I want to bring back this topic of empathy and cultural humility. I think it's so important. I know, systems is hard to break and make a difference, but I think it's the people that has the one-to-one interactions with patients. If we could instill and foster empathy and cultural humility in our students who are going to be the future of nursing practice, I think they could get towards promoting health equity in a very different way than we could, and they could really tackle some of the systems issues as they advance to more leadership role or in the care that they provide. So I would argue, I think it starts with us, with our education, making sure that we really instill empathy and cultural humility, a process in which we help our students continuously self-reflect and be open-minded to differences and think about how they would like to provide the care for diverse communities.
Thank you, Dr. Lor. We have time for another question from our audience. Ian, but I think, is someone, Megan's coming your way.
Ian Forrester is my name. I'm not a nurse, but I'm married to a nurse.
I think it's on.
So, what I was concerned, what I'm interested about, the very first question, Dean Scott, you put to the panel was about equity, and all the speakers talked about that. And I'm a novice in this area, but I have read, I think one of you, was it Dr. Gillespie, mentioned how the difference in health outcomes was so varied across the country and is not as good as in other countries, and in terms of an overall nation. And I've read that the health outcomes, longevity was what you talked about, the life expectancy, varied according to the zip code even. And so when you, I was a bit lost in a way of how to put in practice this issue of equity, because it seems to me that is a government policy. Unless the government policy really sets equity as a goal, then even though you may have noble activity going on by individual nurses, you're really up against a huge mountain. I don't know how you shift that. Maybe I'm speaking out of turn here, but it seems that there needs to be a big change in policy at the national level. I mean, the US healthcare system, based on insurance, is so different from other countries perhaps involved in that survey, where you have universal access. So, as I say, I'm a little bit confused that it's all very noble talking about equity, but unless it's really from the government, central government, then it's a very difficult task, I would have thought. Maybe I'm wrong, but if you could explain how that all works.
Yeah. Thank you, Ian.
And I know that's a hot topic. In a way.
And Barb will help explain it when you get home.
Yes, but, after Tuesday, that really magnified the importance of health policy.
Yes.
You are speaking my language, and it would be my dream to see a shift like that in our country. To achieve equity across the whole nation, you're correct. But we can still make great strides in practice at the local level. And we can empower public health nurses and population nurses to work across the continuum, to bridge the community with the healthcare systems and the public health infrastructure. And we can allow them to make strides in equity locally. Nationally, no. They're not going to be able to do it individually without policy change. But they can still make a difference at the local level. That would be rather significant.
And Dr. Zahner, you talked about transitions in administration. Any recommendations that you have for for nurses, for healthcare workforce, for citizens that you would like to see or suggest in advocacy to help inform or influence policy at the local level, at the state level, at the national level?
That's a great question, and could lead to a long conversation, I think. But, you know, policy is key. When I grew up in public health, I learned about prevention, promotion, and policy as being major ways in which you improve health. So we have to, I think to address these kind of challenges, we have to really educate, advocate. We need to continue to listen to each other and listen to people without making judgments or making assumptions about what we think they know. And we have to try to keep the eye on health. I mean, everybody pretty much wants to be healthy, and pretty much everybody doesn't want to die, you know? So let's focus on what it takes to be healthy, and that's going to help all of us. So education and advocacy, I think, is vital. And just finding multiple ways to do that, because it requires lots of people doing that, you know. And we have lots of organizations and lots of professional groups. We have community groups, and there's lots of different places you can advocate and make policy changes, as Katie said. So we just have to do it. We have to not despair, and we just need to plow forward and continue to advocate for what we know is right. And also, we need to fight for truth as a driver of health policy.
Thank you, Dr. Zahner. We are close to being out of time. I appreciate those final words from you. Dr. Gillespie or Dr. Lor, any take-home message you'd like to share with our audience as we get ready to close?
Sure. The future of nursing, it has to include population health. Population health has to be our focus going forward. And what we do to achieve quality and population health, to create opportunities for everybody to be healthy, isn't always going to look like how we have historically envisioned nursing interventions. It may be that you're out working with the community to plant a garden. It may be that you're doing completely different things than what you ever expected. But that is what the community needs from you at that moment. And what you're about is helping that community find those opportunities for all of them to be healthy.
Thank you. And final comment, Dr. Lor.
I'm going to build on what Katie just said. I think we really need to prioritize community-based strategies that really engage the community to help us as part of the solution. Because oftentimes we go into communities and we think we're the expert, we know it all, but I really want to emphasize that in order for us to really move the needle, advance health equity, even to get at the disparities, we really need to start including communities in our conversations so that they're not left out. And I'll leave it at that. Thank you.
Okay. Thank you. Thank you very much, Dr. Zahner, Gillespie, and Lor. It has been a pleasure to have a conversation with you this evening and to hear your insights and perspective. It's been very inspiring, and I'm sure both our in-person audience and our virtual audience learned a lot from what you shared with us. Could you please join me in thanking our panelists for their presentation?